Next, I invite our next speaker, who is Dr. Arka CHATTERJEE. Dr. Arka will be presenting Cut the Bridge, a case series on Ankylobleph.
Good morning, everyone. I am Dr. Arka CHATTERJEE, and I am here to present a case series on Ankylobleph. I have no financial interest, and I would like to thank my professors. Ankylobleph refers to a partial or complete fusion of the eyelid margins. Etiologically, they can be congenital or acquired and may have syndromic associations which present with multisystem involvement. Clinically, they may cause visual obstruction and may be an indicator of underlying systemic conditions. Now, coming to pathophysiology, during normal development, eyelid separation occurs between 12 to 20 weeks of gestation through apoptosis. But any disruption in this epithelial remodeling leads to the failure of the separation, leading to ankylobleph. They may have various syndromic associations like Chan syndrome or Havel syndrome, which has been depicted here, and other ectodermal dysplasias. Clinically, they may cause visual axis obstruction, ocular irritation, and cosmetic deformities. They may present with bilateral or unilateral presentations and may have orofacial or limb deformities associated with them. Grossly, they can be divided into congenital or acquired cases. Congenital present at birth and may have syndromic or non-syndromic associations, whereas acquired cases present late in life and may be caused due to trauma, burns, or ocular infections. I will be presenting 4 cases of various etiologies. Here is the first one.
This is a case of Ankylobleph filiform adnector. Here, the mother of the baby presented the baby to our OPD at 1 month 10 days of her age. The take-home messages in these kind of cases are to operate on this baby as soon as possible to release the epithelial bands and to prevent any kind of stimulation deprivation amblyopia. This case was done under sedation, where the epithelial bands connecting the two eyelid margins of both the eyes were crushed with a mosquito forceps, and the bands were released individually from both the upper and the lower eyelid margin very carefully. Hemostasis was maintained and a good post-operative result was achieved.
The second case is that of a lateral congenital ankylobleph but late presentation. Here's the pre-operative picture of the patient. We did a surgery where the lateral ankylobleph was cut and amniotic membrane graft was placed and sutured. The post-operative pictures showed resolution of the bands. The third one is that of a 60-year-old lady with lateral ankylobleph associated with ptosis. These are our pre-operative pictures. A surgery was done where the ankylobleph was cut and post-operative relief of symptoms was seen. The fourth and the final one is that of an acquired ankylobleph caused due to Stevens-Johnson syndrome. The patient was referred from a dermatology ward and this is his pre-operative picture. Surgically, the procedure was done where the bands were released and fornicell sweeping was done. Immediate pre-operative pictures showed relief of the bands, but the patient was advised to do the same sort of sweeping with ocular ointment, which he did not follow properly, so it led to a similar front formation. Coming to my take-home message, we have learned that ankylobleph may have various etiologies, may have various causes of origin, and may have can be associated with various syndromic symptoms. But the clinical picture remains the same in more or less all the cases, and surgical management is required for the relief of the symptoms. Thank you.
Thank you, Dr. Arka. I just wanted to know about your second and third case. Both were quite old. So what was the etiology, congenital?
Yes, sir. We took the history from the second case and the third case as well. They they didn't feel any discomfort because of the ankylobleph, but it was present from birth only. But they didn't come to any hospital or OPD for checkup for that, and
Because
so it
maybe
wasn't
it
treated
was
anyway.
because of the laxity of the lateral canthal tendon. That's what I could see the rounding of the lateral canthals. And did you see the lid margin and the lateral canthals in these patients, or you just slit the thing there?
No, no, the
Lid margins were present there in that area, because what I could make out was just rounding of the lateral canthus and medial shift of the lateral canthus. So which can happen, in old patients because of the extreme laxity of the lateral canthal tendon. So
um, the um,
because why they will present so late if it was
yes.
present? So so that's why I'm wondering about the etiology.
We did
So
the
when you had
workup.
cut that time, you could see the lid margin over there in that area.
Actually, the surgery was done by one of my seniors,
Okay.
but the thorough follow-up, the clinical workup was done preoperatively, and provisionally it was diagnosed as a lateral ankylobleph.
All right. Any other question?
That was my question. I was just questioning the indication of the surgery only.